Hi all, and welcome back to Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. And in this episode, we will begin our two-part series on acute coronary syndrome. This is part one, where we will look at pathophysiology and symptomology related to acute coronary syndrome. Sources for this episode include Iggy's Medical Surgical Nursing and Soul's Introduction to Critical Care Nursing. Understanding coronary artery disease means that we need to understand coronary artery anatomy. So a quick review. You should know about the left main artery, also known as the LM or the LCA, which stands for the left coronary artery. This artery supplies the LAD and the circumflex. The LAD, or the left anterior descending artery, supplies the right ventricle, the left ventricle, and the intraventricular septum. The circumflex, sometimes known as the left circumflex, supplies the left atrium and the left ventricle, where the left marginal supplies the rest of the left ventricle. The right coronary artery, or the RCA, supplies the right atrium, the right ventricle, the PDA, and the RMA. Well, the PDA is the posterior descending artery. This supplies parts of the left ventricle, the right ventricle, and the intraventricular septum, while the right marginal artery, or RMA, supplies the rest of the right ventricle and the apex of the heart. Interruption of the blood flow to any of those arteries can cause a specific type of pain called ischemic chest pain. In ischemic chest pain, the patient reports pressure, or a squeezing sensation or fullness from the sternum outward. The pain or pressure may radiate into the jaw, the teeth, the shoulder, the arm, or the back, and is often associated with dyspnea or shortness of breath, and is often associated also with epigastric discomfort or nausea and vomiting. Be aware that not everybody reports the typical type of chest pain associated with myocardial infarction and angina. There is also atypical chest pain, which is common for women and people who have diabetes. And these symptoms include exertional dyspnea, fatigue, nausea, and vomiting without the traditional signs and symptoms associated with coronary artery disease and chest pain. And what is angina, also pronounced as angina? It is chest pain that is usually related to inadequate blood flow to the myocardium. Three different types of presentations can suggest acute coronary syndrome. First, there's unstable angina, also known as USA, also known as rest angina, which is chest pain that occurs without activity and lasts for longer than 20 minutes. Another presentation is new onset angina that noticeably limits physical activity. Then there's increasing angina, that is chest pain that is becoming more frequent, lasts longer, and occurs with less exertion than previous bouts of angina. Any of those three suggest ACS. Aware that not all chest pain is angina, and not all angina is related to coronary artery disease. In fact, there are guidelines that are not indicative of MI. These include a pleuritic pain. This is a sharp knife-like pain associated with deep breaths or cough. Primary pain being distinguished as coming from the middle or lower abdomen. Pain which is localized, especially by the finger, over the left ventricular apex. Pain that is reproduced with movement or with palpation. Constant unremitting pain that lasts over many hours, and very brief intense pain that lasts only for a few seconds or less. Any of those are not considered indicative for myocardial infarction. A very common psychosocial manifestation of MI is denial of the MI. In fact, denial is a very common reaction to MI, and it may delay the patient seeking out healthcare for as long as 2 hours as they continue to tell themselves this can't possibly be a heart attack. Other psychosocial manifestations that occur during a heart attack include fear, depression, and anger. So the term acute coronary syndrome is therefore an umbrella term for clinical signs and symptoms of myocardial ischemia and include the terms unstable angina, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. Unstable angina, or USA, is caused by a thrombus or embolus that nearly completely occludes the coronary artery. So the symptoms occur at rest and usually last more than 20 minutes. They limit physical activity and they have increasing angina. Again, that means the pain is occurring more frequently, is lasting for longer periods of time, and is limiting the patient's activity. Non-ST segment myocardial infarctions, or NSTEMIs, have symptoms consistent with myocardial infarction, but without the persistent ECG ST elevation changes. However, there may be ST depression on the ECG, and the patient will have elevated cardiac biomarkers. An ST segment elevation myocardial infarction, or STEMI, has the characteristic symptoms associated with myocardial ischemia. And in a STEMI, the ECG shows persistent elevation of the ST segment. The patient will also have elevated cardiac biomarkers. It is helpful to differentiate USA from STEMI and NSTEMI. USA has normal cardiac biomarkers without characteristic ECG changes. There are nonspecific changes of a normal EKG that can occur, and this happens after incomplete occlusion and or distal embolization. So you have your angina, but without EKG changes or cardiac biomarkers. In an NSTEMI, there are positive cardiac biomarkers with ECG changes, but without ST elevation. Changes, however, may include nonspecific changes or ST depression. Again, incomplete occlusion and or distal embolization. The STEMI is identified by positive cardiac biomarkers and ST elevation, seen in 2 or more contiguous leads in a 12-lead ECG, and are usually result of complete occlusion. However, like chest pain, you need to be careful because MI is not the only cause of ST elevation, and the prudent nurse needs to rule out acute pericarditis, left ventricular aneurysm, cardiomyopathy, coronary artery vasospasm, and early repolarization. An important skill for the advanced practitioner who's specializing in cardiology is to be able to identify the possible location of the myocardial infarction using the 12-lead EKG. Anterior wall MI will have ST changes in V1 through V6 without reciprocal ST depression and usually involves the LAD. Septal wall MI will have ST changes in V1 through V4 and the disappearance of Q waves in V5 and V6 without reciprocal ST depression and usually involves the LAD. A lateral wall MI will have ST changes in 1, AVL, V5, and V6 without reciprocal ST depression in 2, 3, and in AVF, and usually involve the left circumflex. While an inferior wall MI will have ST changes in 2, 3, and AVF with reciprocal ST depression in 1 and AVL, and usually will involve the RCA, although the left circumflex is involved 20% of the time. A posterior wall MI will have ST changes in V7 and V8 and V9. These are from a right-sided ECG with reciprocal ST depression in high R in V1 through V3 and usually involves the RCA or the left circumflex. An MI to the right ventricle will have ST changes in V1 and V4R, that is a right-sided EKG, with reciprocal changes in 1 and AVL and usually involves the RCA. An atrial wall MI will have PTA changes. Now, PTA changes are similar to ST changes, but instead of just having the ST segment change, it is the entire segment between the P wave and the T wave that is affected. Anyways, these PTA changes will occur in 1, V5, and V6 with reciprocal PTA depression in 2, 1, and 3, and usually involve the RCA. Here we have drawings of ST segment examples. On the top, you see that the baseline, and notice that the ST segment is back down to the isoelectric line. The next picture shows ischemia with tall or inverted T waves, that is an infarct. At this time, the ST segment may actually be depressed, which would represent angina. Notice the next one where has the elevated ST segment and the T wave may invert. This is due to injury. In infarction, that is acute infarction, there is an abnormal Q wave. The ST segment may be elevated and the T wave may be inverted. In an infarction with an older age than acute, there is an abnormal Q wave. An ST segment and T waves are returned to normal. The Q waves indicate a dead zone, that is an area that has already been injured. And this dead zone has a lack of electrical activity that is now part of the heart's electrical impulses. So the Q waves progress depending on the age of the MI. So that there's a normal ECG prior to the MI, then there's the hyperacute T wave changes, there's the marked ST elevation that occurs with transmural injury, pathologic Q waves with less ST elevation and terminal T wave inversion begin to occur during necrosis. Pathologic Q waves with T wave inversion begin to occur with necrosis and fibrosis. And then lastly, again, pathologic Q waves are seen with upright T waves when scar tissue exists, that is, fibrosis of the myocardium. A very important component in the diagnosis of myocardial infarction is the search for components of the myocardium that have escaped into the bloodstream. These are known as cardiac biomarkers, and the troponins are preferred. Troponin I and troponin T are equally useful. You should also know that if you have the troponins, you really don't need to use CK-MB. Further, troponins rise very quickly after a myocardial infarction, so it is important that serial or sequential measurements are used to determine the extent, the severity, and the duration of the myocardial infarction. Recall that it may be high after surgeries like coronary artery and bypassing and grafting, so in these cases, higher parameters, that is, higher levels, indicate a myocardial infarction that occurred after the surgery. And these biomarkers may remain high after reperfusion. Other diagnostics used to indicate myocardial infarction include 12-lead ECG, and earlier in this presentation, we were reviewing some of those 12-lead EKG changes. Also, imaging. Now, a chest x-ray is really not diagnostic for an MI. However, it helps to rule out other problems, including things like an aortic dissection, because an aortic dissection symptoms can truly mimic myocardial infarction. Other diagnostics include perfusion scans using things like thallium, computerized tomography, coronary angiography, which is now becoming more state-of-the-art, and it's simply a series of 64 x-rays in 3D which map out the coronary arteries and any blockages they may have. Also, an echocardiogram may be beneficial to see the movement, that is, the dynamics of the myocardium. And that does conclude this episode, but stay tuned. Part 2 is when we're going to talk more about myocardial infarction. In the meantime, I hope you learned a little bit. I hope you plan on coming back to listening some more. And if you are, I'll see you then. Have a good day.